it's really important to look at where your target is and what the toxicities are associated with hitting that target. Make sure you include that thinking when you're talking about bispecifics.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Schwartz, Professor of Pharmacy Practice at the James L. Winkle College of Pharmacy at the University of Cincinnati in Cincinnati, Ohio, about the use of bispecific monoclonal antibodies in hematologic cancers and solid tumors. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Mo.
Oh, thank you.
Well, I'm ready to learn. This is a topic that I know a lot of people have questions about, so we'll just jump straight in. To start things off, can you help briefly describe what a bispecific monoclonal antibody is? And we can call those bispecifics from now on. And how do they differ from bispecific T-cell engagers, which we might have heard called BiTE?
It's a great question because when you talk about bispecifics, you can talk about bispecific monoclonal antibodies, or you can talk about bispecific proteins. And so what bispecific means is exactly what it kind of implies. There are two targets. So the official definition is that it's an artificial protein that can bind at the same time to two different antigens or to two different epitopes on the same antigen. And so what a BiTE is a bispecific that engages T cells. So TE stands for T cell engager. So one of the targets that are engaged is something on the T cell. The ones that are commercially available to date engage CD3 on T cells, but there are many in the pipeline that are being looked at that may engage T cells in a different way.
Right. Thank you for that. That helps clarify in my mind the differences there. Can you tell us more about some of the most recently approved bispecifics and their targets?
There have been in the last, let's say, year, about 6 bispecific antibodies approved, a couple in myeloma and 3 in myeloma and 3 in lymphoma. So let's talk about myeloma because that's the one that is new agents are coming out this month, 2 new agents. There are a number of new agents that have been marketed in the last year. And the 2 disease groups that have been most impacted is multiple myeloma and lymphoma. Let's start with multiple myeloma. So the target for the bispecific monoclonal antibodies in myeloma was initially BCMA, so B cell maturation antigen. And probably people are familiar with that because that's a target in CAR T cells in myeloma. There are 2 drugs that are approved now that target that specific target. And that is teclistamab that was approved October 2022. And then very recently, elranatamab, which was just marketed this month, August 2023. There is another bispecific that has been marketed in myeloma that has a different target, and that is talquetamab. It was marketed again in August of this year, and it targets, I'm going to say the abbreviation and I'm going to explain it, GPRC5D, which stands for G protein coupled receptor family C, group 5, member D. So the reason this is important is because when we talk about bispecifics, we need to really pay attention to both the target on the cancer and the target for like T cell engaging, because that impacts both efficacy, but also toxicity. Now, in lymphoma, we have 3 agents that have been marketed that target CD20 and also CD3. And so those are mosunetuzumab, that was December 2022. And then just in May, epicortamab. And then most recently in June, glofitamab. And so those are bispecifics that are approved for lymphoma.
It's been a busy past few months. It sounds like lots of new approvals, and clearly none of them are easy to say. So it is, I think, a challenging time for nurses to feel confident and comfortable with all of these new drugs that are coming out. Can you maybe elaborate a little bit more on the specific diagnosis or indications that have been approved for use?
So I think that is one of the most important points when you look at these agents, that the approval of the agent tends to be in the study that the drug was looked at in phase 2 or sometimes 3 trials. And so it is often heavily pre-treated patients who have had to have a number of prior therapies that are included in the indications. So in the 3 in myeloma, it's patients have had to have what would be classic first-line myeloma treatments such as proteasome inhibitors, immune modulating agents, and anti-CD38 monoclonal antibodies. The number of treatments prior to use per indication tends to be 4, but again, that could change as we see these drugs evaluated in other settings. In terms of the lymphoma, it's really important to look at the type of lymphoma that it's approved for. So for instance, when we're talking about mosunetuzumab, that's approved for patients that have relapsed or refractory follicular lymphoma after 2 or more lines of therapy, which is different than some of the other indications. So I'm just going to pick one, the glofitamab. That's for patients with refractory or relapsed diffuse large B-cell lymphoma after 2 or more lines of systemic therapy. So one of the key things I think we need to look at as these drugs come out is what where they sit in terms of indication, knowing, of course, that they will evolve over time as further studies are done.
Is it fair for me to say that none of these therapies are currently used in the frontline setting?
Yeah.
But maybe that's what eventually studies might show?
Exactly. And the other thing that's really important is that these deep and durable responses that we're seeing in the trials with these agents after 3 or 4 lines of therapy is really impressive. But if you really look deep into the clinical trials, often the patients that are receiving these agents in clinical trials have had more than the required 3 or 4 lines of treatment. They may have had 5 or more lines of treatment. So it's really important to kind of look where it sits right now, knowing, of course, that that's an evolving target.
So let's talk more about how exactly do bispecifics engage with the immune system? And you'd mentioned CD3's role in that process, but can you elaborate a little bit more?
I think this is really interesting. And a key point is that the agents that are commercially available that are T-cell engagers, because we do have bispecifics that are not T-cell engagers. Amivantamab is an example that we see in lung cancer. But those that are T-cell engagers at this time utilize activation of the CD3 that is on T cells. So CD3 is a protein complex that is a T cell co-receptor that's really important in activating both the cytotoxic T cells and helper T cells. So think of this as a way to form sort of a immunologic synapse between the target on the cancer cell and the T cell receptor. So when the synapse occurs, you get activation of the T cell and the resulting cytokine release and changes that you need for that immune response.
Kind of sounds like a cytotoxic group hug. You're just bringing everyone together.
That is a really nice way.
So again, let me say this statement and tell me if I have this right. So all BiTE therapies are considered bispecifics, but not all bispecifics are BiTEs.
Exactly.
Sometimes I have to say it out loud to get it to click for me. So thank you for that. Let's talk a little bit more now about the toxicities. And what are some of those key toxicities that nurses should be aware of and monitoring for in patients that have received or are receiving bispecific therapy?
Because bispecifics do engage that T cell and do initiate that immune response, one of the toxicities that has been a challenge has been the cytokine release syndrome. So those practitioners that work with CAR T cells are used to maybe managing this. But remember now, this is going to go broader than CAR T cells. So CRS is certainly one of the boxed warnings on all the agents. But there have been strategies put into place during clinical trials to try to mitigate the severity of CRS. But that is still a key toxicity. And many of these bispecific antibodies are required to be initially dosed in a hospitalized setting so patients can be monitored. Also, you can see things such as the neurologic toxicities that you see with this immune response. But I want to say one of the things that I think can be missed at times is the fact that you need to consider the toxicities associated with your target on the cancer cell. So the example I'm going to use is one that I think could get overlooked easily, and that's one of the newer agents, talquetamab, which targets that GPRC5D protein. It's important because this protein is expressed on keratinized tissue. So some of the toxicities that you're going to see in that trial is not only the cytokine release, but you're going to see skin toxicities such as rash and nail toxicities. So it's really important to look at where your target is and what the toxicities are associated with hitting that target. And as I say that, almost every practitioner knows that when you have a new monoclonal antibody, you always look what the target does and what the potential toxicity associated with that target is. Make sure you include that thinking when you're talking about bispecifics.
I think that's a really great and important reminder. I do feel like I would focus in on and be hyper aware of the risk for cytokine release or ICANS. And so I think that's a great reminder of don't forget what the target is. I mean, I think we are more familiar and comfortable with that in sort of the oral targeted therapies or some of the intravenous ones. But again, when we get into bispecifics, BiTE therapies in CAR T cell, again, I think our focus remains on the severity and the risk of CRS, but let's not forget that these unique and some novel targets will also bring, unfortunately, another whole host of potential side effects that we have to be mindful of. So that's a really great reminder. Are there any other techniques to help mitigate the risk of cytokine release syndrome that are used specifically in these types of therapies?
In terms of mitigating risk, there's been two major ways that have been done. One is a step-up dose schedule. And so one of the key things I would say if you're not familiar with an agent that you're going to be administering, it's really important to review the entire step-up scheme because it's different for each agent. In some cases, patients need to be admitted to the hospital for the entire step-up strategy. Other times, it's just the first dose. So it's really important to look at that. Another way that's pretty interesting that has been done recently is with that drug glofitamab, which is the CD20, CD3 bispecific agent. With this drug, prior to the first dose of the bispecific, patients actually receive a single dose of obinutuzumab. And they do this to try to mitigate the toxicities associated with the cytokine release. So there are new strategies being evaluated to see how we can decrease the incidence and decrease the severity. So one of the things as you look at the clinical trials with these agents, you'll see that a lot of times, even though the percentage of cytokine release syndrome is high, you have to look at what the grade is. And so with these strategies, some agents you can see grade 1 and 2 versus what you would expect if you wouldn't have used some of these mitigating strategies.
That's a really important reminder. And I know that we are always trying to remind and encourage nurses to take a peek at that package insert, look at the label and the information that you can learn. And like you've mentioned from the studies that resulted in the approval and looking at that breakdown of what sort of toxicities were seen. And as you mentioned, the importance of not looking at just the total, but understanding how the grades sort of laid out. Because the number overall might be high, but if you see that the majority of those were grade 1 and 2, that again, that just kind of shifts your thinking and gives you a different perspective on what to expect. And then also, of course, how to educate your patients on what the risks are and the likelihood. So that's really a great and important point. Speaking of, what are some important educational points or teaching nuggets that our nurses can provide to their patients so that they can understand kind of what they're in for when they get these types of therapies?
That's an extremely important question. I think we're going to get to the point where our teaching strategy is going to have to be somewhat tailored to the agent we're giving. So how the drug is given during the step up, what the subsequent cycling is going to be, whether it's going to be a Q21 day cycle or a weekly dosing administration or every 2-week administration after a certain point. So I think some understanding of what to expect going forward, because these are drugs that are given continually in most situations. And so it's important for people to know what to expect. education about side effects, I think, have to include both the side effects you would expect during that initial step up, but then the side effects that you would expect down the line. So when you look at agents that target B cells and infections become a big risk, then you need to talk to them about risk for infection and what to do about it. So I think it's going to come to a point where we step back and educate about the specific agent, include information that it's a bispecific, but not assume because it's a bispecific that it's similar to every other bispecific you may have used.
I think that absolutely brings to the surface how, our educational approach has to change as these therapies become more complex. It used to be that we could pull up a blank calendar and just kind of sketch out the Q3 week once every 3 weeks, or maybe it's a day 1, 8, 15, like sort of the classic kind of schedule and frequency. And as these therapies have become more complex, their dosing schedule has become not only complex, but then also variable and multiple agents given at different frequencies. It's just emphasized that the time that we dedicate to educating our patients and their caregivers and families has to match how complex the science has become. And so we can't expect to sit down and tell them everything they need to know in one visit. The education has to be, I think, ongoing and also partitioned in small amounts that they are ready for and that what comes next, of course, tailoring that to the patient and their family and their needs. But I think it's a lot for any patient and family to kind of take it all in at one single visit. And so trying to think of ways that you can discuss with the patient and over time, give them the information at the right time in the right amount so that they are prepared for what comes next. So I think you bring up great points.
The other thing, Jaime, that I think about a lot with these therapies is that patients go get treatment inpatient and outpatient with some of the agents. And I think the coordination of education between those settings is really important.
Absolutely.
And that's been done really well in most bone marrow transplant settings. But I think it's something as we see these agents perhaps evolve into solid tumor more than we have to date, it's going to be really important to make sure there is some coordination.
Absolutely. It really just highlights the importance of having, nurses in those roles of coordinating or navigating care, depending on what your institution titles those positions, but really helping to create that consistent handoff of, inpatient to outpatient, what happened. And, hopefully many locations at this point have shared electronic health records. So information can be seen, but I'm sure that nobody has a perfect system. My experience is that, there are still challenges, even if it's the same system, but it's a different interface in terms of what you see or how you document. And so creating those processes between units so that that information can be shared, providing that reassurance to the patient that we're going to talk with your nurse, who works in the outpatient setting or works with your physician. Just that's not the burden that the patient should have to bear. And that's something that I think nurses really need to feel empowered to own and to make that process smooth so that not only does the critical information that needs to be shared and communicated back and forth between treatment teams is seamless, but that patients feel confident that we're going to know what happened. Whether we're an inpatient or outpatient, we'll understand what happened on the other side so that any concerns or risks or issues that popped up will be able to be followed and continued to be monitored. So I think that's a really important point. And hopefully, nurses, whatever setting you find yourself working in, understand who those point people potentially already are in your organization. Or if you don't have them, I think that's a great conversation to start with leadership to understand how can we better improve communication. I know some organizations have dedicated navigators or coordinators, which is different than case management, right? Inpatient usually has case managers, certainly a defined and important role, but not exactly what we need in this setting. It's something a little bit more different in terms of oversight of treatment, toxicities, schedules, all of that. So great point that as these treatments get more complex, involving multiple areas, multiple treatment teams, we have to have somebody or more than one person really to help kind of keep it all together. So, where do you see bispecifics emerging in just the overall oncology landscape?
I think about this a lot. And where I see things going is bispecifics, whether it be monoclonal antibodies or bispecific proteins, because we do have a bispecific protein that's not an antibody. I see not only the BiTE type therapy we're engaging T cells, that we may be engaging in the immune response. I think that we're going to see more of those drugs that maybe target two different antigens that may be important. And amivantamab is an agent that's been out since 2021. It's a bispecific antibody that engages both EGFR as well as MET. It was developed because the MET pathway seems to be a driver pathway when resistance develops to the EGFR inhibitors. It actually was found to have a different place in therapy, and it's approved for patients that have locally advanced or metastatic non-small cell lung cancer that have EGFR exon 20 insertion mutations. But that drug, the reason I bring that up is that is a bispecific that isn't a T-cell engager. I think we're going to see more of those. I think we're going to see bispecifics that perhaps engage other aspects of the immune system besides CD3. In fact, those are in clinical trials. And I do believe that we're going to see these more and more developed for cancers beyond the hematologic malignancies. There's a lot of work being done at looking at targets that we know are helpful targets in certain cancers. And I think we'll see more drugs approved beyond the myeloma and the lymphoma and the leukemia space. So that's where I see one thing. But the other thing I see is these agents either being used with other agents earlier in therapy or figuring out where these agents fit in terms of sequencing of therapy overall. And I think that's some of the clinical trial results that we really are looking for. Where does this fit in terms of therapy compared to CAR T, compared to bone marrow transplant? So those are the kind of things I think we're also looking at.
So it sounds like everyone just needs to buckle up because it's coming. I mean, I think that's important to know that, as you mentioned, right now, a lot of action, a lot of activity in the hematologic realm. But for those that maybe are subspecialized more in solid tumors, still get involved in understanding how these are working for those diagnoses and start to educate yourself and become informed, because it doesn't sound like these types of therapies are going away. In fact, they will likely just become more predominant and maybe used further up in the lines of therapies. And so learning now as things are rolling out, and we can all learn together, even if it's not a therapy that's for patients maybe that you care for specifically. I think that it's important to try to learn early so that we can all kind of be ready when it does come to a certain subspecialty diagnosis that we care for. So great tips. Mo, I always learn something new when I talk with you. I always love to hear you talk. I know you've presented at Congress before, and so it's great to talk with you here on the podcast. But as we wrap things up today, we do like to just ask a few quick fire questions to summarize what we've learned. So can you cover what are some common misconceptions about bispecific antibodies?
I think the thing I hear most is that people think all bispecifics are BiTEs. And so we've talked about that a lot already, but I think that it's really important to realize that a bispecific does not necessarily have to be a T-cell engager.
And you're right. I was confused about that until we talked about it today. So thank you for clarifying that for me. What's something about this topic that's not often discussed, but you wish people knew more about?
Where to find information. And I think you did a wonderful job talking about making sure that you look at the package insert, because the package insert is going to tell you a lot of the information that was discovered during their clinical trials. I personally love going into the clinical trials, but the other thing that is really nice to do is you can just search for podcasts and YouTube, like report outs after meetings of the studies, and hear the people that did the study give a short synopsis of what they learned. They bring out caveats that are in the reports, in the literature, in the publications, but that you may not pick up on unless somebody brings it out to your attention. So I think finding information out about these agents and not just trying to group them together is really an important thing.
What additional training or education do you recommend oncology nurses seek out to stay current on the use of bispecifics?
I think there's a great need for those health professionals that don't live in the world of cytokine release syndrome to learn more about how to manage it in a grade 1-2 setting versus a more toxic setting. And so I think we have a great resource in our teams that work in bone marrow transplant and that are going to work with these agents in-house to help teach all of us how to approach patients, how to do education for patients and patients' family. And so I think that's one of the key things.
And then finally, do you have any recommendations for resources for patients or even other providers, maybe not in the oncology space, who want to learn more?
There are so many review articles on this topic now because it is of such interest. And so if you work in myeloma, there are great review articles looking at these agents in myeloma, not only the ones that are marketed, but the ones that are going to be marketed. So I really think going to the literature here is where you can get a lot of information.
Absolutely. Well, thank you again, Mo, for your time today and all of your expertise. Do you have any final comments to share with our listeners?
No, I just think it's really helpful that ONS provides these podcasts to help people hear about some of the things that they are going to touch in their practice, but is not at their practice right now. So I really appreciate this opportunity.
Well, thank you so much for all of the great information you've provided for us.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.